Welcome everybody to the first of our clinical network meetings for 2021. I just want to start off by acknowledging our Indigenous peoples. We pay our respect to the Wurundjeri and Burrong people, elders past, present and emerging, and extend that respect to any First Nations people who are here today. We acknowledge that Aboriginal sovereignty has not been ceded and remains strong in their enduring connection to land and culture. So yes, we are at the first meeting of 2021, and I just want to acknowledge that we've got a name change. We've dropped the rural to acknowledge that our network, the reality of our network is that we are statewide, and we're welcoming and picking up colleagues from all around the state. So welcome to tonight's meeting and to any new people who are here tonight. We've got a bit of a space for what's going on around the region. So if you wanted to report, that would be an opportunity. And just also to acknowledge that Kylie's not well, and that's why I have opened up the meeting. So we send our best wishes to Kylie. She's off on sick leave for a little while, and we'll keep you updated on how she's going. And Patty is our clinical lead for tonight, but you'll notice that Patty's not sitting beside me as she normally would. She's been called off to theatre, so it's a wait and see. She may or may not be able to attend. So we'll just continue on with the meeting. And welcome to everyone again. So just like you to introduce yourself in the chat function. That would be best, and just because we are spread over the state, if you use your mute when you're not actually speaking, and if you've got any questions, use the chat function, and Nissa and I will monitor the chat as the meeting progresses. And just to remind you also that we do record the meetings, so if you've got an issue with that, just let either Nissa or myself know by email, or on the agenda there's the search admin email address as well. Okay, so thanks for all of that. And I am going to hand over to Carolyn just to give us an update on 1800 My Options, and then we've got presentations from Lou and from Mary Ann around delivering IUD services and medical abortion in a rural setting. So over to you, Carolyn.
Thanks, Kath. Hi, everyone. Good to see everyone back this year. 1800 My Options, we are continuing the service. We've got a few trends that I think are relevant to the group that we've been observing on the phone line. We've had a slight increase in callers from the Gippsland region, and we're also getting slight increases from some of the rural areas like Southwest and the Grampians region as well. Hard to really say what that's about, but it has been noticeable in our statistics. We are continuing to have a slightly increased number of people requesting contraception services. So it's around 5 or 6% of our callers are looking for contraception at the moment, which is significantly higher than previous, where it was around 2 to 3%. We are also seeing continued increase in demand for pregnancy options counselling. So that's sitting at around 5% at the moment, whereas previously it used to be sitting around 3.5%. We are doing a little bit of work in some of the rural areas across the state and with providers. So we have a small budget at the moment for stakeholder engagement. So a lot of the providers who are on our database will be receiving some info both by email and in the mail with some little provider packs that we want to give to our fabulous providers, because we're coming up to our 3-year anniversary on the 19th of March. There's going to be a social media campaign as well as a few other things happening to celebrate the fact that we made it to 3 years and we're still going, and it's been such a successful service. And I think also quite relevant to that is that we are currently finalising the evaluation of the 1800 My Options service. So we will have a report for that available to everybody in this meeting, as well as all of the providers on our database. And I think some of the really key things with that we found in the evaluation were that 1800 My Options has been really key to making sure that women are connected to services. Another interesting point is that over 40% of our callers have healthcare card or pension cards, and so that shows that we are seeing a significantly disadvantaged population when the average population number for healthcare card holders is about 7% in Victoria. We're also seeing higher than the population average of Aboriginal and Torres Strait Islander women and migrant and refugee women. I think that's it. I'll pass it back to you, Kath. Thank you so much.
Thanks, Caroline. Look forward to the 3-year celebrations on the 19th of March. Now, Lou and Marianne, have you got a, I'm not sure, I've got both the PowerPoints and I think Nisa has uploaded them ready to share. So have you got a preference for who goes first in your presentations?
Marianne.
You're dobbing off again. I have been aware of this, Marianne. So are you, Nisa, are you able to share? Oh, sorry, Lou, just to clarify, which is Marianne's? Is Marianne
is Marianne able to talk? Because she was a bit worried about whether or not she had
you'd have to do a presentation.
Marianne was going to share a really, really interesting case study of how creative services have to be, and just from what Caroline was saying in terms of the challenges of working with Medicare ineligible women. And mine was just a little bit in regards to our conversations around some of the barriers, and Dr. Pornima and Dr. Chris Sass also just gave me a few ideas from private practice and why maybe there's still a reluctance within GP practices, and what's the actual quality, what's actually the cost of the quality of the care that sometimes gets missed when we're just talking about financial situations. So Marianne, are you up?
You're just saying in the chat. Oh, can you go again, Marianne? It doesn't. Gee, we held it together for 2020. We fallen apart first meeting in 21. So
I can go first if you want to. Yeah, that's fine.
Nisa, are you able to share, or I think I've got sharing privileges?
Yes, I'm sharing now, hopefully.
Oh. Yeah, thanks. Thank you. So can everyone just say, I'll just go to the slideshow, will I? Or Nisa, can you just go to the slideshow? Thanks.
Is that working?
Oh, we can kind of see both of them, but that doesn't matter, I don't suppose. Has everyone just got the screen where they've got the first slide and then the second slide on? Is that right? To the side, yeah?
Yeah, I can see both your first and second.
Yeah, I can see it.
It just probably would be good just to see if we can just do one slide. They're not going to take very long. It's just really to start the conversation, I suppose.
Is that working now, Lou?
Look, that's what we got too, so that's fine. We can just keep going. So,
Lisa, you just need to change the display settings.
oh, thanks, Siobhan.
No worries.
Can you see that? Is that better?
Yes, thank you.
Okay, great.
Beautiful.
Thank you.
All right. So one of the questions I asked Dr. Ponema and Dr. Sass was just in regards to some of the barriers that may be present. And this is not new to our group. It's just, I suppose, for those who perhaps hadn't put it all together, it's just really in regards to the provision of IUD services within private practice and the barriers of early medical abortion. So one of the things that a lot of staff who work in a private practice will look at in terms of the lack of resources and how to actually set up services, you do need to have resources such as equipment and consumables, and how that comes out of the budget from that practice if you're not a senior partner or if you happen to be having to purchase them. And we did do some breakdowns of, you know, sterilising reusable equipment versus single equipment only, but we haven't really brought that to the table today. We're just really talking about, I suppose, the overall barriers. So the issue in regards to staff resources in terms of emergency managing of cervical shock for an IUD. One of the other issues was in regards to the lack of expertise with the other doctors in the clinic. So some of the GP registrars that we are working with at the moment and in the previous 12 months had identified that they may be the only GP in the private practice that they'll be moving on to that will actually provide IUD services. So that, I suppose, is something really in regards to how how they can be supported as they move into becoming a fully accredited GP and providing these services. We did look at the remuneration for work done compared to other GP care, and we've got some, I suppose, some breakdown of that. And the cost of the consumables. With early access to early medical abortion, really a lot of it was around setting up the service. And this actually came from for us who have been running this service for a long time, I suppose we don't really think about way back when we actually had to start negotiating with only our employer, local pharmacies, the local emergency or urgent care to provide that service in the community. As much as there's a lot more acceptance from pharmacies, and there's, as we know, a greater list of pharmacies, but from a practice point of view, they still have to go through those processes. The MBS item for MTOPs, still the stigma of providing that service. That's probably should be number one, I suppose, in regards to some of the comments that I've heard from some women just in 2021. The cost of providing the service, as in the remuneration for the GP, how the practice will need to provide services for women in regards to after hours, and the policies and procedures and who's actually there to support them. So, is that right? Okay. So some of the challenges we talked about with the complex and longer appointments than required, and it's very typical, and I know all the nurses in tonight will agree that what might appear to be a very simple consult will turn quite complicated very quickly once a history is obtained and circumstances are discussed, and that just cannot be accommodated in some practices. And of course the Medicare rebate doesn't reflect this and doesn't reflect that kind of sensitive care. So we often know that services are provided by a GP or a nurse who's passionate about the service, and we certainly know in some of the rural towns around Bendigo that when that GP leaves, then that service finishes or concludes until another GP comes into that into that practice, or if a GP goes on maternity leave. And there's no one to follow up with that service while that GP is on maternity leave or on paternity leave. So that's a consideration. So the difficulty management to see the benefit of providing the care if the rebates don't cover the cost when they leave, and who pays for the consumables. Thanks, Nis. So we just wanted to look at meerkats because they're really cute. And then, thanks, Nissa. And this is just a very quick breakdown of the difference between providing for a Medicare rebate for the comparison. So we can see providing a sexual health service with an IUD insertion consultation, a 30-minute consult, which is the minimum really, looking at all the extra items that can be added to it. That's the rebate to the organisation. Whereas if a GP can provide a 30-minute GP management care plan, that's the rebate to the organisation for Medicare. Usually in a lot of services there's actually at least 2 consults for early medical abortion, and for us it's a nurse and then a GP, and the Medicare rebate is for that time, whereas with a GP care plan review, which a nurse can do, and a GP can, I suppose, pop in and make sure there's nothing else extra required, then that is the rebate. And then there's the extra costs for the consumables, and of course not factored into nurse time. Some GP practices have the nurse practice incentive program, and other nurses are funded in a variety of ways. So this is just really, thanks Nissa, you can take that slides down now. I just really wanted to, when we're having our conversation about whether or not people align with that, whether that makes sense, or whether services out there have found creative ways for barriers not to exist. I'm very interested to hear what people say.
It's interesting that your service is a number of years old now, Louise, and so it's a few years since you've had to negotiate through the referral pathway and getting your management team on board. And I was also interested that you say stigma could be on top of your list. Do you want to talk a bit about that, about how your service experiences that, or what you notice? Because I'm aware that there's a few representatives here from other services who are just in the process of setting up a medical, well, I suppose I'm assuming stigma relates more to medical abortion, but yeah, just wondering if you've got any reflections on that.
So I suppose I forget that because we have been providing this service, and we do believe that in our region our service is well known, and that the referral pathway into our service is quite varied, from self-referral to a support worker to, of course, a lot of our referrals from other GPs. And I suppose my reflection is that I continually to be a bit surprised when I get a story from a woman it's taken her quite a while to get to a service where they'll actually provide early medical abortion, and that the process there has actually been quite traumatic. And the example that I would say is that seeing a GP, the GP confirming a pregnancy with a urine test, and then sending this woman off for bloods and an ultrasound and saying, come back and see me, and not once saying, I can't provide this service, even when this woman has said, I don't want to continue with the pregnancy, but said, go and have the ultrasound, you'll have to have that, go and have the bloods, you'll have to have that, then come back to me. And it might be 2 weeks down the track. And so the urgency and the understanding around that, I continually to be surprised that that there is, you know, health pathways out there, there's access to good information, that these women still continue to have those barriers, and that, and then the opposite is that a woman coming in acknowledging that she is pregnant, that she doesn't want to continue the pregnancy, has done home pregnancy tests, and the GP just saying, I can't support you here, you've got to go there, and then basically just giving them a phone number and saying, you know, goodbye. So giving them the appropriate phone number, but really not providing any way of a support to acknowledge that this is, you know, acceptable and that that's fine and there's a service and, you know, just down the road and, you know, they'll look after them. So I suppose my reflection is that in 2021 I get a bit cross that I'm still hearing those stories. I don't know what other nurses or other GPs or other service providers have, but it's still, yeah, absolutely there.
I think, can you hear me? Sorry.
Yep.
Yeah. I think just the stigma thing got put on the list because one of our GPs put that as a possible thing. I think that people worry that there'll be a stigma attached to setting up a service in your clinic, but in actual fact, I don't think that we've faced any stigma really, the clinic itself. It's more the thought of it. I think people worry that there will be stigma attached to their clinic providing medical terminations of pregnancy. But yeah, I think as workers and as an organisation, we haven't actually had, there's been no sort of backlash or anything from the community, which I think is important for anyone to know who's thinking about setting up that service at their work.
Yeah, it's interesting, isn't it? Because that's always the big thing around, it's always the fear that there'll be a community backlash.
Yeah.
Anyone else with comments around stigma, the costs associated with IUD service?
I think what the presentation really demonstrates is that it just highlights how it is challenging for providers to either earn enough money if they're just providing sexual health services. When you look at the Louise's presentation, it highlights that doctors working providing other services have greater capacity to bring in more money, and if they're getting paid on an incentive-based salary, then you know it's easier for them to earn more money if they're not just doing sexual health, because the rebates aren't the same for these services. That's what the presentation really highlights.
I would agree, Marianne, that I think that just the preventing factor, I think, for GPs taking up the service within their practice would be exactly that incentive. They don't get remunerated for it. They don't have funded nurse positions, so it's hard to then generate that income from it. And I suppose, and stigma would be the other thing that people are fearful about. And I would agree with you that I think for our organisation at Gateway Health, we didn't have any backlash for setting up our service at all, and still haven't really to this day. But we do hear quite a few stories of what Louise talked about in people being held up by other GPs who may have an objection by just sort of stalling tests, getting them to come back and not giving a good referral pathway to people to get to a service. So yeah, I would kind of see all those things that have been said.
Yep. Is Kath still there?
Yeah, I'm here.
Oh, you're there. Cool.
Yeah, it's interesting, isn't it, that, you know, both the Bendigo and the Gateway service has been embedded in the community for some time, but there is still those blocks from GPs external to your service that, you know, obviously have got some objection, or, you know, you assume that it is an objection as opposed to just being you know, lacking clinical skills in terms of dealing with this? I know.
I actually think it's a bit of both, Kath, because we get a lot of people, a lot of women that have been referred elsewhere. They often get referred to the hospital. So it's kind of, even though it's on the primary health network pathways and all that kind of stuff, we get a lot of women who get referred to the hospital first, and then the hospital bumps them to us. So there is a lot of lack of knowledge, I suppose, about what the processes really are in the area. Yeah.
And just thinking about the long list of barriers and challenges, have you got any reflections on what you've needed to do from a management perspective to encourage your management to maintain those services? Well, I'm thinking particularly of IUD services, because I know that there's various costs associated with that in terms of consumables and nursing time and so on.
I think we're probably just lucky that we're the hub, so therefore we have to provide these services. But I can certainly see if they were to purely run it from a money perspective, then you could see why they would say it's actually not worth providing it. And if GPs are on a set wage, then it doesn't actually impact on their income, but it impacts on the income that comes into the organisation, because that money comes from Medicare. But for GPs who are getting paid based on what they do or what money they bring in, then, you know, they've got to spend time reflecting on, gee, I can actually earn more money than this doing something else. Yeah.
Always comes down to that individual champion, doesn't it, or team of champions within an organisation to advocate for the service. What about any of the other people around the virtual room who perhaps don't work in a hub and might be providing this level of service? You got any reflections that you want to add?
Yeah, hi, I'm not on video. My name's Angie. Can you hear me?
Yeah, we can, Angie. Thanks for that.
I'm an IUD provider in a big practice, and I will say one of the main issues that I have is people not turning up at the last minute. So we'll book our morning of 5 IUDs, but they will often cancel themselves out at the last minute, rebook another appointment, or else they say they have symptoms of some highly infectious disease, and of course they can't come in. And so we're left with only half the numbers, and there's no financial backup for that at all. And if we book 45 minutes, because we do the consent form on the day, so we actually can have quite a lack of income for the morning. We go ahead, but we have to have a nurse booked. So we can't just slot them in at any time. That we have to put that whole morning aside.
Yeah, that's a risk, isn't it? I actually heard in the abortion and contraception clinic this morning here at the Women's, out of 6 women that were booked, just 1 woman came for her appointment. And this is apparently, just we've got to check this out, but apparently people who were booked get a SMS message. So we're wondering if something happened with the automatic, SMS messaging. But yeah, it's a lost opportunity, isn't it? And you can't replace that time. You'll never get it back.
And other people, would have wanted to take those appointments. Thank you.
Thanks, Angie. Anyone else want to make a comment about their experience of providing IUDs or early medical abortion?
Hi, Kath. It's Adrian here. Sorry, I missed the presentation a bit early. Apologies. Really quickly, I thought I'd just sort of add in, I think we're here at Gippsland Lakes, we are very early on in establishing services. And I think, the conversation is quite right in terms of being able to resource the medical component and in a setting where we are Medicare driven for that person's availability, to have discrete time that person is available to work with us is shaping up, I think, to be a little bit of a service barrier, and trying to make sure that we can promote that person to be available with us as much as we can, particularly in the early days, because we just need to make sure that things get off the ground.
Yeah, thanks, Adrian. And this is where your model is working across different practices in a nurse-led or nurse, sharing the care with the GP who might not be at Gippsland Lakes Community Health. So that's another challenge. I might hand over to Mary Ann now, and we can hear you, can't we, Mary Ann? We'll find out that problem. So,
Yep.
Lisa, if you wouldn't mind loading Mary Ann's presentation.
Yeah, so this is just a really brief case study of a scenario we had during COVID. So I've called it MTOP from afar and thinking outside the box. So yeah, if you could just move on to the next slide, that'd be great. Thank you. And I'm doing this on my phone, so it's actually really hard to read everything. But okay, so I had a phone call from one of the nurses working in Swan Hill at, I think it's called Swan Hill District Health. And they normally provide MTOP services, but every now and again they don't have someone there who can prescribe. So they rang up, they had a 34-year-old woman who was 6 weeks pregnant from a non-English speaking background with very poor English, no Medicare card. They had organised for her bloods and her ultrasound to be done. She doesn't drive, didn't have access to really anyone who could travel with her to come to Bendigo, and it was during COVID, so that made it a little bit, even a little bit more trickier, or actually it might have made it better. So initially I had a chat to our registrar who was doing MTOPs, and asked her how she would feel about doing a tele and over the phone consult with this woman. And she said, oh, no, I don't know that I'd feel comfortable doing it just straight up over the phone, because it's too hard to know, whether there's somebody else in the room with her, whether there's any coercion, how do we really know whether she's consenting, and plus who pays for it. So they were the doctor's concerns initially. So then we had a little bit of a discussion about how we could make it work. And I suggested that if I spoke to the nurse up at Swan Hill, and if we could arrange for her to get the woman into the clinic, and for the nurse to be there with the woman, and then we'd get the interpreter on the phone at the Swan Hill clinic, so they would organise the interpreter, and then the GP from our practice would do telehealth into the room where everybody else was there, and the registrar agreed to do that. So that's actually what the plan was, and that's what we ended up doing. So, and just the next slide. So the GP felt confident and comfortable that consent was really obtained, because she could see the person's body language and could hear the questions being asked, and then the interpreter replying to the woman, and so she felt comfortable with that. She also was able to confirm that there was no coercion, and so she just provided the script, an air script over the phone, and the nurse from Swan Hill provided the follow-up consultation as well. So it was a really good outcome for a difficult situation. And who got paid for doing it? No one. So there was no Medicare rebate. I especially asked the registrar to do it because it didn't affect her income, so she would still get paid because she was on a normal wage, rather than someone who's getting paid based on who they see. Yeah, anyhow, so that's what we did. Has anyone got any thoughts about that?
Sounds like a really good example of the personal, professional network working in a very flexible way, which best address the woman, the pregnant person's needs. because I mean, if she doesn't have a Medicare card, she wasn't. It was always going to be an issue around how to get paid, wasn't it?
Yeah.
And given COVID, she can't travel.
And in the past, if we've had someone who doesn't speak English, we would often still bill them, like they would still pay something so that the doctor got some reimbursement for the person attending. But because it was over the phone, you know, there was no way around that. But we were able to provide the service, which was great.
That's a good outcome, Marianne. Do you know if, just Ange from Gateway Health, do you know if then, I suppose the patient would have had to pay full price for the medication with no Medicare?
That's actually a really good question, Ange. I wonder whether the hospital would have been able to provide it, because it was actually through Swan Hill Health. So I probably should have investigated that. But yes, I guess if not, she would have had to pay full price for the medication, which is very pricey.
It's about 300, isn't it?
$385 or something like that.
385, right?
Oh, I don't know. I've just plucked it off the top of my head, but I know it's 300 and something.
It's in the 300s, I know.
Yeah.
Close to that, yep.
Yeah, but given it was through Swan Hill Health, I wonder whether they would have provided it at the hospital. I'm not sure, Ange. It's a good question.
Yeah, I wonder if someone was advocating for it at that end. It highlights the barriers, doesn't it? Does anyone else have any comments before we go to what's happening around the region?
I was just going to ask Marianne, what happened with her contraception? Was there able to be any follow-up on that?
Yeah, so the nurse, because the nurse who was working from Swan Hill, they normally run the clinic that we would here in Bendigo. So she was able to follow all that up. And they have doctors there that will prescribe medication for contraception. They just didn't have an MSG step provider at that time for a couple of weeks. Yeah. And it was also, from memory, it was like the week before Christmas or something, like just to add in a little bit more challenge to it.
Yeah, because that just adds to the cost, doesn't it? As well. Like, you know, if she doesn't have a Medicare card, the cost of any of the contraceptions is quite expensive as well.
But even have your ultrasound and your bloods
and
everything, it's like $800 and something dollars to by the time you get all of that done. Yeah. Very pricey.
Well done.
Thanks for that, Marianne. Has anyone got any comments before we move on? Not that we've come up with any wonderful solutions to how to provide this level of service in a sustainable way, but we know those challenges are there, and we keep advocating within the department. I can see Danielle Mazza is here, and I know the important work that Sphere is doing around advocating at very high levels of government around changes. But
I guess, Kath, one of the things that really highlights, like, if that woman did have a Medicare card, technically we still wouldn't have been able to bill her because of she hadn't been seen by a GP in the practice in the previous 12 months, which, for these type of services, the chances of it being one of your normal clients is pretty rare.
Can I just ask, it's Danielle, just on the advocacy issue, if anybody has kind of from the hospital service or from one of the providers involved documented the case and written to an MP highlighting this case?
It's a really good suggestion, Danielle. We always, I write up the practice, the meeting notes from this network. Yeah, perhaps that's something that we could, you and I could work on, Marianne, and perhaps if it was Nicole from Swan Hill.
Yeah, it was Nicole. Yeah.
Danielle, would you suggest both local? I suppose it'd be federal, wouldn't it? Rather than state.
Yeah, I think I think it needs to be like from a health professional stating, we want to draw your attention to equity of access issues for women, we highlight, you know, this recent case, de-identified, of course, highlighting the issues and the cost to these women and who, you know, and also the cost to the health professionals involved in terms of their time and this not being rebatable. And we urgently seek your support and then, you know, put in a couple of recommendations, because if we don't actually tell the politicians, they don't know that this is happening. You know, rural health, Minister for Rural Health, Greg Hunt, local member.
Yeah, they're really good suggestions. Actually, I'm in Northcote in Melbourne, you know, in Metro Melbourne, and we had our local member, state, just doing a meet and greet in the street, and so I approached her and told her about, initiated a conversation around access and equity to sexual and reproductive health services, and she wasn't even aware of the policy, the women's health, her own government's women's health key priorities statement. So yeah, I think it's a good point that, you know, using any opportunity to involve politicians. Just wonder, you know, if we're going to approach a local member, it would need to go through management as well. So perhaps that's something that we can have or take offline, Marianne.
Sure. Because as you can imagine, there was a lot of phone calls. Like there was a lot of toing and froing to get that to all happen. So it's a lot of unpaid work.
Yeah, that's right. And I think it's a really good example of the professional network at work, you know, looking for creative solutions. We better move on, unless anyone's got any last moment comments. Okay. What if we just go round the regions? I know there's a number of people who are attending their first meeting who I haven't met anyway. So do you want to put your hand up or let me know in chat if you want to talk about what's going on in your region? Anyone want to kick it off? I'll nominate Adrian. Adrian and Heather, do you want to talk about what's happening in Gippsland?
Adrian first. Or you can start, Adrian. Well,
please do. You go.
Seb, you're on mute, Heather.
No, I've had a bit of trouble with sound and things. Perhaps Adrian should go.
All right. Well, thank you, everyone. It's lovely to meet this network. So we're the last hub to come online for Victoria, servicing the Eastern Gippsland region. And we've basically now developed a service and have now opened our doors to engage the local community for women's health, sexual health and access to medical terminations. And we're effectively now in the position of promoting ourselves in the local community and doing a lot of community engagement activities to make sure that local people know that our service is available and engaging with local stakeholders as well. So fortunately, we're in a position now that we're hoping to have our clients make themselves known to us, and we've got a slow drip feed at the moment after 2 weeks of being open. We've got a slow drip feed of client activity. So good, happy to report we're open for business.
Thanks, Adrian. And Heather, did you want to add anything to that?
Oh, I'm having a bit of trouble with.
That's okay.
How's that? Can you hear?
Yes.
No, I can't get the work to work.
That's all right. Thanks
Sorry.
anyway, Heather, and welcome aboard, Adrian and Heather. It's good to have
Thank you.
the last hub of this incarnation anyway. We're hoping for more hubs one day, but yeah, be really interested to see how your model of care is developed. Anyone else from around the region?
Okay, thanks.
Well, I could report from the Clinical Champion project. We're also doing some work in the Gippsland region, just trying to support the either established or new and emerging providers of early medical abortion and surgical abortion care that are operating in the Gippsland region. As Caroline from 1-800 would know, that there are very few entries on 1-800 My Options. So while there is some service delivery in Gippsland, it's often not accessible and available, or not so much available, but it's not accessible to people who are looking at the 1-800 website or who are ringing 1-800. So we're just trying to work with those providers to support them and develop the link with that network. And perhaps those providers might feel the need to register themselves on 1-800 My Options so that women and pregnant people can more easily access the service. So that's one thing that we're doing. We're also looking at redeveloping the information on our website that's externally, like our internet site, and just, you know, cleaning it up and making it more relevant to providers. We have got a couple of clinical policy guideline procedures that are now available and on our website, and we wanted to put it all together in one more central location that would support clinicians. So that's a working group that we've kicked off late last year, and yeah, we're looking at developing that for this year. And also the other thing that we're working on internally is that the Clinical Champion project have received some funding from DHHS to develop an e-module for medical abortion. And it's in the very early stages of development. And the time frame is that we're hoping that it'll be on board late this year. And eventually it will sit on the women's education platform, be free and accessible by registration. So they're the key things that we're working on. Anyone else from around the region? Any hubs or any other services? Do you want to go, Ange?
Yeah, okay. I'd just like to, we're pretty excited because we have a new prescriber who's online tonight. So Alison is one of our GPs, and she's one of our GPs who is the refugee health GP. So that's really exciting to have Alison on board as a prescriber, and particularly to work with the refugee clinic is really great for us, and also just providing backup when our GPs are off sick. So that's really exciting. That's in Wodonga, not in Wangaratta. So yeah, so now we have 5 prescribing GPs, which is really exciting. I suppose our challenges, and it continues to be our challenge, I think ever since we kind of hit our capacity pretty early on, is just getting new GPs, local GPs, to take up prescribing instead of just referring to our service, because we're at capacity. At the moment, I think we have a 2-week wait to get in, because we had to kind of restructure our appointments for staff sustainability. So that's our constant challenge, is how do we, you know, get other people to take up prescribing and not just referring to our service all the time. And I think it comes down to all the things that have been highlighted tonight around remuneration, and you know, it's hard to get that to happen. But we also just have a new prescribing GP that's sitting over the other side of the border, who we really are welcoming and happy. We met with her, and she's happy to take referrals from us or inquiries, and also from the Wagga kind of Griffith further afield in New South Wales. So that's really exciting. I think our other challenge is we've had a fair bit of sick leave with prescribing GPs due to COVID and a whole lot of other factors, and that, I suppose, puts pressure on just that. When appointments are quite limited, it puts pressure on rescheduling people. That's why it's been really good to have Alison on board, because she's been really great, and we owe her lots of chocolate and lots of things. I think she's just been able to step in and take on that sick leave when people have been away, but it puts a heap of pressure on reception, on nurses, on GPs to try and fit rescheduling in, and it's a constant challenge. But yeah, I think we're cruising along, and we hope we get refunded as a hub like everyone else, and maybe get more money as a hub. That would be awesome. But yeah, that's kind of where we're at.
Thanks, Ange. That sounds like there's a lot going on there. It's interesting you're noticing changes across the border too, because that must make a difference to your, you know, to the capacity for your service to deliver.
Can I just add a little something there, Kath? So just recently we started getting a lot more referrals from Swan Hill and from Kerrang. And so then I rang the Swan Hill Hospital with Nicole and just checked in to see were they back prescribing, and they were. So they were going to ring the Kerrang clinics in some of the surrounding towns and just let them know that they're offering a service, because women were kind of unnecessarily travelling more than they needed to access services.
Thanks, Marianne. So just to clarify, Kerrang
isn't providing a service at the moment. They did have a GP, but she's on maternity leave. And so, and perhaps because Swan Hill weren't providing it for a while, they were just automatically sending the referrals to us. Yeah, and so I thought, oh, well, I'll just check this out. So I rang Swan Hill and they said, yep, no, we definitely are at the moment. So, yeah, and it'd be much simpler for women to go to Swan Hill, because they have to go to Swan Hill to have their ultrasounds anyhow. Yeah. So, yeah, so it's just a matter of letting Swan Hill know that there was, and Kerrang is in their region, they're happy to provide a service within a 100-kilometre radius. So it'll take some of the load off us.
Yeah,
hopefully.
Yeah, that's right. And Swan Hill's an interesting case study too, because they had, you know, despite the number of GPs that are in town, you know, like 2 years ago, they didn't have any GPs who were willing to come on board with early medical abortion. But, you know, we managed to work closely with a couple of the nurses in Swan Hill, and they've done a fantastic job just to raise the profile of the need for early medical abortion services in Swan Hill, and managed to get a couple of prescribers through their hospital network between the visiting ONG providers and their medical director. I'm pretty sure that's still the case, Marianne?
Yeah, that's my understanding, Kath. Yep.
Okay, thanks. Anyone else from around the region, especially the people who are new here? Do you want to talk about what you're doing in your service?
I'm just going to jump in. I'm Romy. I'm a GP from West Gippsland, and I'm not currently. I was driving before, so sorry I couldn't say hello on the chat. But I've literally just signed up to 1-800 My Options because I've been meaning to do it for ages, and I'm really keen to get involved. But I think all of the issues that were raised before, I think it seems a difficult area. I'm also a forensic medical officer, so regionally and in Metro provide sort of sexual assault exams, and so I'm always really keen to have sort of systems in place for patients to access after that as well.
Oh, that's fantastic, Romy. Welcome aboard on all sorts
Thanks.
of levels to this network and to 1-800.
Thanks.
Yeah, well done. So just to clarify, are you in general practice in West Gippsland, or are you at the hospital?
No, I'm in general practice. I actually practice in Moe, so Latrobe Valley, but live in West Gippsland. So I am, yeah, and have been excited by all the talk about possible things starting up, and then it seems to have hit a bit of a brick wall again. So yeah, and there's lots of GPs, well, there's at least 2 GPs at my current clinic who are really keen to try to, you know, be part of developing a more a better service for people, because there seems to be a real absence of options for women in this area.
Yeah, absolutely. Oh, welcome aboard.
Thanks.
Yeah, your efforts are much appreciated. Anyone else want to report in the last couple of minutes? No. Okay. Just checking the chat. No, no one else. I can't see anyone's hand going up, but there's a lot of black screens looking at me. Okay, well, thanks everybody for your attendance tonight. We wish Kylie all the best for a speedy recovery, and Patty's still in theatre at this moment, so yeah, she'll send her apologies as well. Our next meeting will be on the 25th of May, and we'll send you a Zoom link when we send the agenda out, and I'll write up some practice notes from this meeting, and that will end up on the Resource Hub website, on the search website. And yeah, we look forward to the 1-800 My Options evaluation and birthday party on the 19th of March. So that's just 10 days away. All right, if there's nothing more, I will close the meeting. Yep, okay. Thanks everyone for your contribution tonight. Great to see everybody. Stay well.
Thanks, Kath. I just worked it out.
But we'll get there.
Thanks, Kath.
Yeah, thanks everyone.
Thanks, Kath.
Ciao. See you later.
Thanks, Kath.
See you later.